Right. Hello, everyone. Thanks so much for your attention. I had a very mortifying scheduling issue this morning. My name is Kirstyn Brownson. I'm one of the breast surgeons here at the University of Utah and Huntsman Cancer Institute. And I got the privilege of working on this program, or this project, with one of our awesome global surgery fellows this year, who is off presenting in another state today. So we're excited to share this with you, and again, thank you for your time. Specifically, we're looking at, or going to be discussing, our multidisciplinary tumor board and looking at implementing this in low and middle income countries, specifically Mongolia, which is where we implemented this. So our country of interest is the country of Mongolia, situated between Russia and China. This country has a population of about 3.2 million, but 50% of the population actually resides in the capital, Ulaanbaatar. The other remaining population lives in small cities of 50,000 persons maximum, or in nomadic groups. And so the thing that we think is really exciting about this is this tends to be hopefully something that is high impact, because we are implementing this tumor board in an area that has 50% of the country's population. The country of Mongolia has access to public free healthcare. However, navigating this free healthcare system and what would be incorporated in this free healthcare system, you can see could be really challenging when the majority of the population, or a large portion of the population, 50%, lives in really rural, underserved areas. The main city, or the capital city, Ulaanbaatar, has all the tertiary hospitals. Breast cancer is a problem globally, but in Mongolia it's about the 5th most common primary cancer amongst Mongolian women, with a rate of 6 in 100,000 women developing breast cancer in their lifetime. The incidence really ranges by geographic region, and while there is a cancer registry that is established in the country as of in the last 10 years, it's really limited in its composition of rural data. So what I'm basically saying is we don't know what the true incidence of breast cancer is in the country, because about 50% of the population is not accounted for. 90% of patients who are diagnosed with breast cancer in Mongolia are diagnosed at a late stage, which is not uncommon in low and middle income countries. And there is a 42% survival rate, where the rate in the United States for women who develop breast cancer is in the 90%. So a pretty big disparity. So the National Cancer Center of Mongolia was our partner for this project. They came to both the University of Utah and the University of Minnesota, our other collaborator, in the last year. They were established in 1961 to take care of patients with thoracic, gynecologic, abdominal malignancies. And they wanted to create a breast cancer center rather than just being a group of practitioners taking care of patients with breast cancer. 80 to 85% of all the breast cancers within the country are referred to the National Cancer Center of Mongolia, and 85% of the breast surgeries in the country are performed at the National Cancer Center of Mongolia. In addition to surgery, they also offer radiation, chemotherapy, palliative care, and pathology review. This slide just kind of highlights that this was a collaboration between not only the National Cancer Center of Mongolia and the University of Utah, but also the University of Minnesota. We did perform a needs assessment with the Mongolian team to see kind of what they wanted, and again, their big overarching goal was to create a breast center and to have us help them in that creation. And after kind of doing our needs assessment, we decided that a good educational tool would be to implement a multidisciplinary tumor board that was international, University of Utah, Minnesota, and Mongolia, and it was held virtually. This tumor board meets every month for about 1 hour. So why would we choose this as our educational platform? We know that in high-income countries, multidisciplinary tumor boards are really important in improving the type of care that is delivered to patients and the education of all of the different specialties that make up that tumor board. In both breast cancer and colon cancer and sarcoma and many other cancers, we see improved patient 5-year survival rates when the patient's case is discussed at a multidisciplinary tumor board, decreased time to treatment for those patients, improved guideline adherence under national guidelines, National Cancer Center guidelines, decreased surgical complications, and decreased recurrence rates. The thing that is novel about what we did is we don't know what the effect of multidisciplinary tumor board care is in low and middle income countries because it's just not done. But I think COVID really challenged all of us to look at things a little bit differently and see what we could do virtually, which led us to extend ourselves in different ways. Our multidisciplinary tumor board had good attendance from multiple specialties in both the Mongolian group and the University of Utah and University of Minnesota groups, meaning that it wasn't just a bunch of surgeons or a bunch of medical oncologists, but people from all the different specialties, which really makes it ideal. On average, the patients that were presented by our Mongolian team were about 38 years, so these are young women with breast cancer. The most common breast cancer that was diagnosed was invasive ductal cancer. That's the most common breast cancer, so we would expect that. The stage at presentation was across the board late stage presentation, stage 3 and stage 4. And then we have a smattering of different tumor types. The majority of all breast cancers that women develop are estrogen and progesterone positive, but not surprisingly, we saw a lot of HER2 positive cancers and triple-negative breast cancers presented at this tumor board because they wanted our opinion on what we could do with these really aggressive cancers. For our results, the most common procedure that was performed was a modified radical mastectomy. That is something that is rarely done in the United States, but sometimes is necessary because of the extent of disease that we're dealing with. About 9% did not get surgery. And then 16% of patients were late-stage patients who underwent surgery prior to chemotherapy. And this is kind of something that should never happen. If someone is late-stage, we want to prioritize their systemic therapy that's going everywhere in their body, killing cancer cells, over surgery. We also took a look at the type of questions that were asked by our colleagues, and the majority of them were treatment-type questions. What should we do in this setting? Lessons learned. We learned pretty early on that we were hoping to discuss way more patients than we had time for, that the presentations were unorganized. And I don't mean this in a pejorative way. I mean that when we talk about patient care, with breast cancer or any cancer, we always dial it back to what stage is that patient, because that tells the story of what their survival is and what other treatments we should implement. And our Mongolian team came to us and said, hey, we want to learn how to work as a team to take care of breast cancer patients. And it was clear from the presentations that they were used to taking care of these patients as siloed individuals. So we implemented a standardized multidisciplinary tumor board template, which we use every day in our tumor boards here, that kind of tells the story in a way that everyone is used to communicating about patients with in the United States, and then also to give them a way to start telling the dialogue of their patients and their care that they've received to date, so that we can start integrating really essential bits of information to make treatment recommendations. In conclusion, the strengths of this international virtual multidisciplinary tumor board was that we were able to gather people from all over the world at 1 hour once a month to discuss really complex cases, which is kind of, something that is not always we're able to do, to herd all the cats. It was low cost. We did it for free, and it is highly replicable. I will say the weaknesses were language barrier, and but that is something we now have an interpreter for, and we're hoping that that can help. The other thing that I'm really excited about is that with this template, we can start kind of talking about why the template is so important and kind of bringing it back to the template, because that will help with the other things that we noted, which were weaknesses, which was deviation from these standard templates and then poor compliance with recommendations. And again, I think this is a communication issue. between both our teams in the United States and the Mongolian teams. And if we get on the same page, I think we'll have more success in the future. Thanks again for your time, everyone.